Thank you, Sam.
And I will mute.
Good morning, everyone. Thank you, everyone, for being here today. We've got a number of folks still joining, and then we'll get started. All right, well, welcome everyone. We are so glad that you are here. My name is Jennifer Barron-Prawl, and on behalf of the South Southwest MHTTC, we welcome you to today's webinar. We're really happy to have Dr. Jason Schiffman presenting on the topic of education, special education, and accommodations for students with psychosis, working with youth, families, teachers, and schools. So thank you for being here. I'm going to just start off just to orient you. We are on a Zoom webinar platform. Your video capability is it's disabled at this time. You can use our chat feature and our Q&A pod. Be sure to share your ideas and resources via the chat box, and feel free to again enable the closed caption if you need it. Just a quick acknowledgement. This presentation was prepared for our MHTTC network under a cooperative agreement with the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. So know that the opinions that are expressed in the presentation are the views of our speaker and don't reflect the official position of SAMHSA. All right. Our MHTTC network uses affirming, respectful, recovery-oriented language at all of our activities. And this is particularly important to the work that we do when serving others. So we invite you to join us in reflecting on what language is the most strength-based and recovery-oriented for our learning space today, so that we can grow in our ability to affirm and support others through our use of language. And along with that, we are dedicated, our South Southwest team is dedicated to providing events where everyone feels welcome. So we ask that everyone here helps us to achieve a safe, respectful, inclusive, and positive environment for learning. So essentially, we just ask you that you're all kind to one another today, and just be mindful what you put in your chat box in the Q&A pod. And again, this presentation is being brought to you by our South Southwest MHTTC, and we're here in the Southwest region is Region 6, which is in the purple, and we focus on supporting mental health workforce development within Texas, Oklahoma, New Mexico, Arkansas, and Louisiana. Few housekeeping items just to kick us off for today. As I mentioned before, we're on a webinar platform, so be sure to use the Q&A pod for questions. We've got Dr. Sam Resnick here, and myself will be helping with logistics, so know that Sam will be helping answer questions, and we'll be able to help answer anything that pop up even from a logistic perspective, or questions about what you're hearing from Dr. Schiffman today. Again, please use the chat box that's here for networking. Y'all can earn 1.5 CEUs for today's session, and know that I'll email you that certificate following the presentation. We will be recording today's session, so you saw that record button started. We'll house all the recording, the slide deck, as well as a handout that actually is available even right now, and we'll put that in chat here for you soon. That will all be sent to you then after the presentation as well, so you'll have that at your fingertips. So that'll be good. We're just very happy you're here. So just know that all the presentation material will be available for you. All right, so without further ado, it really truly is an honor to have Dr. Jason Schiffman here with us today. Dr. Schiffman is a nationally known clinical psychologist for his work serving people at clinical high risk for psychosis. His psychosis research refines the identification process of people at risk. It elucidates the effect of psychosocial interventions, uncovers mechanisms reducing stigma, and attempts to address health inequities. In today's webinar, Jason will be providing information and tangible suggestions on how to effectively work with schools, families, and students on behalf of high school students with psychosis. I have had the privilege of working with Dr. Schiffman over the past 5 years, and I feel really lucky. I'm continually impressed with Jason's intellect, his commitment to serving others, and his depth of compassion. It's really wonderful to have you here today, Jason. And with that, I'm going to pass the baton for your presentation.
Jen, thank you so much. It's really my honor and privilege to work with and collaborate with you. You and the MHTTC team are outstanding. And you were talking about an emphasis on kindness, and you resonate that, and so does your partner Sam. But the many people are kind, but it's your unique intersection of kindness and excellence that I think makes you such a great leader, and makes the community that you've built so amazing. So I'm happy to be a small part of it, and happy to talk to everyone today about this topic. So let's get into it. All right. So I'm just going to look at you, Jen, to give me the thumbs up that it looks okay. You can see the slide. So education, special education, accommodations for students with psychosis, working with youth, families, teachers, and schools. We got some stuff to cover here, and I'm eager to partner with you throughout our time together so that we can grow and learn as a community, as a team. The objectives here: describe federal laws that can be used to support students with psychosis, identify differences and components of IEP and 504 plans, generate a list of actions that can be taken to support students with psychosis in schools, and develop the tools required for an individualized strategy towards collaboration with schools and families. But this will sort of take the form of the following outline. Overview of psychosis, and talk about psychosis as it might look and be detected in schools. Then we'll talk about supported education as a foundation, which will be a springboard for us to think about individualizing educational programs within schools, especially for our kids in high school, as Jen was saying. The role of school and how schools can be so important in the mental health services, not just for psychosis, but for an array of mental health challenges that students might experience or people might experience. We'll spend some time talking about distinctions and characteristics of 504 plans and IEPs. And then hopefully this last point will be infused throughout, like ways in which we can help, ways in which we can help each other, and ways in which we can help some of our most vulnerable brothers and sisters with risk for psychosis or early psychosis. So, all right, I'd like to start by sharing a story. This is a story about a family I worked with several years ago that really illustrates what I'm hoping for here. I've of course changed the names, but let's say Miss Smith. Miss Smith called me about her two children, her 28-year-old son Thomas, and her 17-year-old daughter Jane. Thomas, he had developed schizophrenia at the age of 20 or so, dropping out of school and leaving home abruptly at around that time. He was now living without housing in a distant part of the county, completely removed from social connections, healthcare, employment, and educational opportunities. He'd really, at that point, had sort of refused to speak with his family. Miss Smith, she couldn't talk about Thomas without breaking down in tears. And in her words, she said she had, quote unquote, lost her son. Miss Smith primarily, however, came to me to talk about her daughter, Jane. Jane had been fun-loving and bright and was at that time poised to attend college. She was a junior then, I think. And things began, unfortunately, to change recently for Jane. And Miss Smith was worried that Jane was sort of following the path of her brother. Jane began having unusual ideas. Some of these she just couldn't shake. And this was leading her to feel mistrustful of others. Jane began to describe herself as feeling like she was, quote unquote, going crazy. And then she started talking about killing herself. So if you just take a second and think for a moment, like what would you want for this family, and just begin to generate some thoughts and inside your mind, and think about like what would be best for them. It's such a broad question, and there's no single right answer. But for me, like the way I framed it and the like contextualized it and created like an umbrella was to think about building connections with and for the family. To connect, in this case, a very vulnerable member of our community who might be struggling with issues potentially related to psychosis or psychosis risk. And if it's possible, we want to connect them with folks early in their journey. Like, whereas with Jane, we have the chance to connect with her prior to the manifestation of the illness catching hold as it had for her brother, Thomas. By finding folks so they don't fall through the cracks, I think we can offer them more brighter lights of hope and promise. Now, hope is always there, no matter what or where you meet someone in their journey. But earlier on, that message is brighter. And in this case, I was really happy to report that I was able to work early with Jane, in large part because her mother reached out to us so early, and we were able to connect and effectively collaborate with her school. And it was the work with her school that I think really helped facilitate her getting back on track. There was a coordinated effort to wrap her with academic, emotional, and behavioral supports that included, among other things, compassion, patience, flexibility, kindness, and an understanding from school staff and teachers to get her through. And I think the collective work seemed to, at least from my perspective, influence her long-term trajectory and wellness in very positive ways. And this is the goal. This is the goal of all we do, to increase the likelihood that someone will have a positive trajectory and be able to live a life of their choosing, a life in the community, a life that they really want to live. And schools and our work and all the work that y'all do can be a big part of contributing to that. Now, one of the biggest motivations for early identification and work with folks early on in the course of psychosis is this concept referred to as duration of untreated psychosis. The reason it's so important is because DUP, as it's known for short, duration of untreated psychosis, is associated with just about anything negative that you can think of. So longer DUP is bad. Now, if you think about this arrow here as the passage of time, at this point could be thought of as when a person crosses a threshold for psychosis. And this point is where intervention is implemented. Now, the duration of time between these 2 points is called the duration of untreated serious mental illness or psychosis. And in the United States, on average, DUP or duration of untreated psychosis, this time frame lasts 2 years. Of course, as I mentioned before, the longer this period, the worse the outcome. So traditional long-standing programs like outpatient care, if you're lucky, coordinated specialty care, they're offered for folks further along in their mental health journey. And this is where we saw Thomas. This is where he received his first care. And unfortunately, he quickly dropped out for a variety of different reasons. There is room to move the needle even further back in time, much further back, working with folks before they cross a threshold for psychosis, soon after the onset of risk, has the potential to prevent further deterioration and possibly prevent psychosis altogether. Now, this is where we were able to connect with Jane, and I think, at least in part, contributed to making major differences for her. So sometimes we refer to like the point of time when the risk symptoms begin and when a person gets treatment as duration of untreated illness. But in Jane's case, there was no duration of untreated illness, really. We were able to work with her right away. And for folks like Jane, sometimes we can forestall psychosis if that's their like sort of where they're destined, where their outcome is likely to be. Sometimes we can mitigate its implications if they in fact do develop psychosis. And sometimes we can contribute to prevention, which I think is sort of what happened with Jane. Now, schools can play a huge role in reaching these goals. It makes common sense, but schools are a good place for mental health services. This is where most kids are most of the time. This is just like one study that one of my friends shared with me during another presentation that I thought illustrated the point. But in this study of kids who were getting trauma-specific treatment after Hurricane Katrina, 57 of 58 who were approached in schools started treatment, and 91% of them finished treatment. Whereas only about 23% of kids offered care in local communities through mental health clinics began treatment, and then only 15% in total completed their care. So this study wasn't designed to illustrate this point, but I think this point is really important in that it is just one of probably many examples that affirm common sense that schools are a great place to engage students across a variety of different contexts. Academics, of course, but mental health as well. And this is important because kids, especially the risk for psychosis, although this is like risk for many mental health concerns, the highest range or age range of risk between 15 and 25. So, sort of in the high school, traditional high school window there. This, as I have emphasized before, psychosis in schools is sort of a no-brainer. Like nearly all youth at risk for psychosis or with early psychosis are in school. Not all, but many. And there's been some evidence to suggest that many providers have experience, maybe not working with kids day to day, but in this survey, 87% of surveyed school providers reported involvement with a youth who had some symptoms of psychosis at some point in their career. All right. Okay. When working with schools, it can be challenging. All right. There are some barriers in some cases, and connections and communication can be challenging, but are also like the things. These are the things that will like break down these barriers. So some of the challenges you might face just at a very basic level, creating a trust between yourself and whatever role you're playing and the school folks as well. And maybe even having the opportunity to like connect with somebody that could be a champion or an ally within the school that can help break through some of the barriers. Things like consent and assent, getting permission slips to and from parents, bureaucracy in general, like large counties or school systems, privacy rights, stigma not just for the like internalized stigma about the person maybe seen within the person that has the mental health condition, but also their friends and other kids in school and teachers, administrators, staff, as well as sometimes counselors. So stigma like is pervasive. Following up, managing teacher schedules and teachers' priorities as they tend to have large classes with not a lot of support. So all these things can create some challenges when engaging school folks in an effort to create some sort of connection for a potential client with early psychosis. And furthermore, attention to psychosis somewhat limited in schools. And this is a slide from a study that we did several years back where basically we just asked mental health providers if like what they specialize or like what population they specialized in, with the categories being adults or youth. And then we asked them sort of how comfortable they were working with psychosis, how much training they had with psychosis, and then also like how comfortable they were working with developmental considerations and kids and families and schools. And what we found should be no surprise to anyone that's had any training in mental health. But there was a gap. We had a gap here, which is to say that youth-focused mental health staff, they tended to report being undertrained in schizophrenia and related disorders, and don't feel comfortable working in schizophrenia. However, they felt really strong in working in schools and families, and they understood developmental considerations. To compound the issue, the adult-focused mental health staff in our study, they tended to be undertrained in working with families and youth and schools, and may not be sensitive to developmental considerations and contextual factors, but they had more comfort and experience working with psychosis. Now, to further complicate things, public mental health systems, including schools, tend to be bifurcated around this time of transition, this transition-aged youth window. So you're 17, the next day you turn 18, and then everything sort of changes. At the same time, if you're 17 and beginning to have psychosis symptoms emerge, graduate from high school, whatever, then there's potential really to fall through the cracks. And this all contributes to longer duration of untreated psychosis. And of course, this is typified in how schools are set up and how we train folks. So there was a subset of folks in our study who reported being sort of specialists in this transition-aged youth window or emerging adulthood phase of life. And they actually felt like they were prepared to work with psychosis and prepared to work with developmental considerations. So I think until we break down our bifurcation of systems in the way we approach mental health and other things within our community, we're not going to have like a big outpouring of folks who are trained in this transition age youth window, because the educational system follows the societal systems. So we start with the societal systems, and then maybe the educational systems will follow, and then we'll have a workforce that's really built to help support this unique developmental window that corresponds with people at risk for psychosis. So something for us all to strive towards in terms of thinking about our leadership opportunities and change of policy. Anyway, okay, so psychoeducation in schools. schools can be part of the solution if the problem is long duration of untreated psychosis. One project that is really quite well done and famous was done several years ago now, but in Norway and Denmark. And they had this like well-rounded, like anti-stigma educational outreach throughout their entire community and throughout these counties. And schools were a big part of this. And what they were able to find was that they could reduce duration of untreated psychosis in the community from 15 weeks, which is already really good, to 5 weeks, with schools like sort of leading the charge in this. And other research suggests just in general, familiarity with psychosis, like coming to a talk like this or whatever roles that you are playing in your community, and then sharing that knowledge, like if you know a lot about psychosis, sharing that knowledge with school folks, this increases confidence and increases screening and the likelihood that we find folks and detect folks who might be experiencing early psychosis. So I mentioned it can be challenging to engage schools, and attention to psychosis exists, but it's limited. But the silver lining here, and I think what I think brings a lot of promise, is this idea that screening and referral is very possible in schools. And some work has shown that it's not just possible, but it's also very effective. So one thing I'll mention, this is from a study that my graduate student Thomas pioneered, and I guess about 10 years ago now. But this was a study. Basically, what we found is that teachers can help predict who's at risk. And in this study, we were working with kids who had a parent with schizophrenia, putting them at increased risk of developing psychosis themselves genetically. And we assessed these kids when they were around 11 to 12 years old. Teacher ratings were a part of that evaluation at that time. Then years later, we followed these folks after the kids passed through the risk window of psychosis, and we determined their diagnostic outcomes. One of the strongest predictors of children at age 11 to 12 weren't showing symptoms of psychosis, but one of the strongest predictors of who would eventually develop psychosis were those ratings from those teachers. And this is just one small study, but it suggests that teachers can be helpful in detecting the future risk of psychosis. I'm going to talk more about screening in general as we go along. And this, in terms of considerations, implementing screening in schools, partnering with schools to maybe integrate some screening things. I have a few ideas I wanted to share. The first is like, who's doing the screening? Are you using teachers? Or are teachers the ones sharing the screening tools? Administrative staff, counselors, who's like giving the surveys out? And in these screenings, I'm imagining, and what we try to implement are like self-report tools that students can take briefly, like almost like a checklist, or like any other mental health screening that might be integrated within schools. I know this isn't easy, but it can be really helpful. Some of the things you have to consider, in addition to who's doing the screening, budgetary concerns, as like sort of I think an underappreciated comment that I want to make here is about attendance. So some of our most vulnerable youth and students aren't, their attendance is spotty. So it could be if you do screening on a day when odds are that a kid that might be at risk, I shouldn't say odds are higher that a kid at risk won't be in attendance that day that you do the screening. So following up and maybe doing screening on multiple days can help capture or catch more kids. Important questions when thinking about whether or not you want to implement screening is like, is it universal, like everybody in the school, or is it folks that just come to the counseling center, or what? And then I think a really perhaps the most practical question to ask is, if you want to engage in screening for early psychosis, what screening tool would be best? And some thoughts on this that I'll share. And I think really there's like some great options. So the one tool is called, that I'll start with, is called the Prime Screen. And this was developed by some of the authors of like the sort of thought leaders in identification of risk for psychosis. So I like that one in large part because it's short. It's only 12 items. This next questionnaire is called the Prodromal Questionnaire Brief, or PQB. And this is a great measure. See, like first author is one of my friends, Rachel Lowy, who's just a brilliant leader in our field. And this one is actually, they're all free, but this one is, these two are free. But If you go to a website, Mental Health America, they have screening for all sorts of mental health concerns, and you can access the PQB there for free and use it there. The behavioral assessment system for children, our BASC-3, has what they call an atypicality scale, and you can use that. The reason I mention that is that some folks already use the BASC in schools. It's kind of similar to the CBCL, Child Behavior Checklist, which I also have listed here, which there is some data to suggest that the thought problems scale within the CBCL and the YSR, its self-report complement, are good for identifying folks that might have psychosis risk or early psychosis symptoms. And I mention these because these are comprehensive. They go well beyond psychosis risk. They screen for depression, anxiety, attention problems, conduct disorders, and the like. And because these are implemented in many cases already, you could piggyback and use the information about psychosis. The last one that I want to mention is this 2-item screen. I'm going to come back to this one in a few minutes. But this is something that that my team and I developed a few years ago after working carefully with some community providers. In this case, this idea actually came from a counseling center in a school where they said, you know, Jason, we like screening, and this 12-item measure you have is good, and it's kind of short, but screening is really hard. You know, the intake battery already takes an hour. We don't have time for 12 items, and this is a fairly low base rate issue. So I said, okay, give me another shot. Let me see if I can find a shorter way to do this. And my friend and colleague, a student at the time, Peter Phelan, subjected all of our data to item response theory, and he came up with like different patterns of 2 items that could be pretty predictive, not as good as the full screening, but pretty good. And I'm going to share those items with you momentarily, because I think just those 2 items provide a pretty good first screen that could lead to a second screen that could lead to a potential referral. Okay, screening in general, these self-report tools, they have all sorts of strengths. Help find people not in services, reduce duration of untreated psychosis, increase the efficiency and accuracy of deeper, more thorough clinician semi-structured interviewing, and then they can be used to monitor folks. So like in our mental health clinic, we give the prime screen every week or every time our clients come in, just to keep track of if their symptoms are continuing to progress. And also, I like to emphasize that the act of assessment in and of itself is curative and healing in some ways. There's a lot of data to suggest that assessment is treatment. So anyway, I'll just throw it out there. But of course, there's a few caveats to screening too. And I thought I'd share a few studies that give some of the like nuance around screening and the importance of considering contextual factors when screening young people. This is a study led by my former graduate student, now professor, Pamela Rakshan Ruakhtar, who looked at screening in schools and found that youth, when they were filling out these self-report questionnaires, the younger they were, the more likely they were to over-endorse or to say yes to questions in a way that was true to them, but wasn't consistent with the meaning behind what we were anticipating. It wasn't about clinical high risk or psychosis risk. It was about other developmental considerations. So there wasn't a shared understanding between us as the assessor and the younger people in our sample. So we had to talk to them and make sure they understood. But as kids got older, they understood better. And so the bottom line here is that some of these screening tools that I'm recommending have to be used with a grain of salt when you're assessing kids as young as 12 to 14. So you see the specificity is lower, meaning we were getting more false positives. Here's another study. This one was first authored by my former graduate student, Zach Millman, who's now a postdoc at in the Harvard system. And he said he was really curious as to whether or not the prime screen was as effective or was effective across demographic groups. In this case, comparing the effectiveness of the prime screen for Black participants and white participants. And what he found was that I'll highlight this here, the p-values, statistically, there was a statistical link between how a person scored on their self-report and their clinical interview of risk for psychosis, the gold standard if they had psychosis symptoms. The self-report screening tools worked better, in fact, or were statistically related to outcomes for our white participants, but our Black participants, the link wasn't statistically significant. So in general, on average, our Black participants were filling these forms out, and it wasn't predicting psychosis or psychosis risk as effectively as it was for our white participants, leading us to suggest that, at least in this sample, that you need more context, and it wasn't an effective, and it could perpetuate sort of discrimination, otherness, and marginalization. So you have a broader issue here of false positives. Again, the idea that there wasn't a shared understanding between what the measure intended to assess in early psychosis and how the folks who were taking those measures interpreted those questions. More context was needed. We had to talk to them. Okay, so I alluded to the 2-item tool, and I do think that this is like a really important component to early screening. And so if there's anything like practical or tangible that I share with you today, this would be one of them. If you ask, you don't even have to have you don't even have to say this verbatim as far as I'm concerned. Just like, ask a person, do you ever hear the voice of someone talking that people cannot hear? And have you ever felt like someone was playing with your mind? If someone says yes to either of these questions, it would be worthwhile to probe a little deeper, continue to ask them what they mean by this, maybe give them one of these other self-report tools that I mentioned, have conversations about the potential for psychosis or psychosis risk. The predictive power of these 2 questions is pretty good for just 2 questions. Now, that second question, have you ever felt someone was playing with your mind? You get a lot of false positives from that, not about psychosis risk, but about other stuff. So just bear that in mind. But if you have that conversation and get a better understanding of what they're thinking and what they mean when they say yes to that, then you'll know what path to pursue. Okay, so that was sort of my thoughts about screening in schools. And now I want to shift a little and talk about supported education. And supported education sort of has it's a framework, and it usually is designed to help folks further along in their mental health trajectory to re-engage in education after a period of mental health challenges related to psychosis in many cases. But I think there's principles that can be applied to early psychosis and psychosis in high school. So this table provides I don't know, foundation and places that we can think about supported education in the context of other things that you might be familiar with, like case management and supported employment, with supported education being on the right there. And if you know about case management, or I like to think of it as more like coordinated care, or supported employment, then there's a lot of commonality between these ways in which we work with folks and supported education. The difference, though, I think it really comes in this last cell here. Staff must know education system, financial aid, personal support, academic accommodations. And some of these things are the things that I want to spend some time thinking about as we continue in our conversation together. So there are 8 principles of supported education that I like to think about, or that are there and I think are cool. And I want to stay on this slide for a while because I think it's worth going over these 8 principles and how they associate with supported education. I tried to find an image for each one of these points to kind of have it stick in your mind and spice things up a little bit, but we'll see how I succeed on that. But bear with me on these. I think the first one, look at that. I don't know what that even means, but access to education and positive forward progress. That's the first principle. I think that aspirationally sounds great. Students who want to return to school or stay in school should have the opportunity to do so. That's it. That's mic drop. A main point within this principle is that the goal isn't just to keep the student busy. It's to help facilitate long-term goals, to educate, to help them grow. And that is the spirit. It's not just whatever, occupying their time. Okay, second one. If a student wants to go to school, they should get these services. As you see these students driving to school. Psychiatric diagnosis, symptoms, cognitive impairment, history of drug or alcohol abuse, or other problems shouldn't keep a person from pursuing their educational goals. No one should be excluded from receiving supported education. if they're interested in continuing in their schooling, and they're willing to attend class, and they're willing to give it a try with supports. 3, all right, early is better. This is about DUP. A quick response here, coupled with support and encouragement, helps consumers return to the promise of a productive role. An ounce of prevention is worth a pound of cure in this and with early psychosis in general. Let's see, the fifth point, educational support integrates with mental health care. Right. And this is about like coordinating education with mental health services, and the treatment team, ensuring that mental health practitioners, and not just the educational specialist, if there is one on the team, support the client or the consumer's goals. All team members should be integrated together and like, sort of aware of everybody's goals within the team. Point 5 is about not being time limited. So some folks struggle, and sometimes it takes time. So if we can expand the timeline, we can have folks have a better chance of recovery if they're not like on the clock, so to speak. The 6th principle of supported education is being client driven. And as Jen was saying at the very beginning about like, the values of the MHTTC, being client driven and in our language and our deed is really important. And here, students, we have to, like, this is common sense, that they're most motivated and work hardest when and strive to get something that they want when they're the ones that are in charge, rather than working for somebody else or somebody else's goals. For this reason, student preferences should in large part guide all of the engine behind how we support our students in schools. Let's see, number 7 is strength-based. All right, supported education emphasizes existing strengths that students can use, and they use them to promote educational as well as their life goals, which education should presumably support. Inherent in this principle is the idea that growth will occur and hope is realistic. And then the last one that they have here, the 8th principle, is that the role of the student is meaningful. And I think in the field of mental health, sometimes overlook the importance of having meaningful roles, like, connecting with others and feeling like you're contributing to society. We're all defined by our roles, the roles that we play, and students with psychosis, no exception to this. In fact, I'm on the record as saying people with psychosis, students with psychosis, they're far more similar than people without psychosis or students without psychosis than they are different. We all share so much in common. Now, being a worker, a student, family member, friend, these are all meaningful roles, and they give context for a meaningful life. Okay, so those are some good principles that I think ground us. And even if it's not like traditional supported education that you're employing, I think these are good things to live by and work on, especially when working with kids in schools. All right, so supported education, it can identify strengths and challenges. Now, I have some screenshots of some resources that I think could be useful. And in this one, this is from you see the link down here. But if you Google SAMHSA supported education, there's like toolkits that you can download, and within these toolkits are like some cool resources. And one of the things that I just think in general is really helpful clinically is the use of checklists, especially checklists that have like some ideas built into it. So you'll see here like examples of strengths and potential problems, like concentration. Is that a strength or potential problem? Study skills, meeting deadlines. And when you're beginning to take stock and listen and learn from your client about how they're doing well and also potentially how they're struggling in the academic setting, a worksheet like this can begin to develop the conversations that you need to have to really understand how they're doing, to be able to develop a personalized plan with them. And then it says academic at top, and then you see like coping issues, restlessness, making friends, racing thoughts, easily distracted, all sorts of different things here that if you were completely open-ended, you might miss some. And if you use this to inspire some semi-structured or open-ended conversations, you can get a lot more out of it. So let's see what else I have. I have some other goodies within this. Okay, present situation. You look on this side here. What are the main reasons you enrolled in the supported education program? does, even if they're not enrolled in the supported education program, you can ask some of these questions like, what are your goals? Career educational exploration, help with applying for financial aid, help with enrolling in school, whatever. This may or may not be relevant. You can tweak it to the needs of your client as you're sitting in front of them. But improving math skills, like, who doesn't need that? All right, and then on this other side here, you have interest inventory. Again, a tool within this system, this toolkit that has all sorts of things. Like, for instance, here, maybe someone is good at gemstones. I I don't know what a gemstone, like an interest in gemstones is, but some folks do. And so having this checklist allows me to generate more ideas than I would on my own. All of this is, again, in the service of understanding the individual picture of the student that you're working with so that you can begin to develop an individualized plan, leaning heavily on strengths and interests that they might have. More resources here as you're having these conversations with folks. What types of challenges or barriers have you faced in the past? Or do you think may happen in the future as you return to school? So in this case, this is a question for someone that maybe was hospitalized, and you're getting them to draw upon some of the things that have worked in the past and some of the things that haven't, and maybe predict or anticipate what could do better for them in the future. All right, so some prompted questions here that allow more of a full picture of what might be some of the strengths and challenges that your client have. More stuff here. Check the barriers that apply to you: transportation, past failures, side effects from medication. All these things become grist for the mill and can be found in that link. More stuff here. This I kind of like, because this is like encouraging mental health providers or folks that are supporting students to think about what they can help specifically and tangibly their students to learn with. So all students can learn new skills through teaching or observation. That's the tenet or the foundational principle there. And so you might think about developing skill lessons or helping students practice new skills, monitor new behavior. And this other one, students need a range of support and resources that continues as long as they're needed. Assessing skills, how's like your ongoing assessment and measurement of how they're doing. Determining when a student needs support rather than a skill. Sometimes you just need accommodations. Determining the nature of the support, the kind of resource wanted. Again, trying to get a real fine-grained sense of what the student needs so that you can begin to implement that within the team. So I have been talking a lot for a long time, and I wanted to open it up a little. And if you're willing, you could click on that QR code. And I have a question in there about jargon. Jargon you hear in schools and what you think it means. So I think the link to this could be in the chat too, if Jen or Sam could send it there, or maybe they already have. But let's see what lingo that you all hear in the schools and what you think it means, and if it's confusing, and then I'll just kind of share that on this Mentimeter. I've seen some answers today. All right, hang on one second. As they flood in, press enter. All right. Okay, so this is great. Already I'm seeing stuff that I don't know. Like the first one, I don't know what CAP stands for. Executive functioning disorders. That's a good one because it's so broad. Like, what does that mean? People throw around the term executive functioning, like everyone should know exactly what that means. But in truth, is it differs from person to person, and how different people define it. I have DID. I assume that's like dissociative identity disorder, but I don't know. Sometimes you'll see these different things. Let's scroll through here. Accommodations. We're going to talk a lot about accommodations. 504 plan. I'm going to try to define that. But so 504 IEP. These are we're going to after we look at some of these words here. First of all, I should have thanked you already for this, but thank you for throwing in answers here and engaging in this conversation. That means a lot to me. I don't know what many of these things are, but I do know that we can talk about IEPs and 504s a little bit. But one of the things is like I'm a behavioral health specialist. I'm a psychologist, and I learn most about IEPs and 504s from my colleagues who work within the schools. So I'll have like definitional framework, but then how these things like apply to your world and your student are really sort of where the action's at. Diag, probably diagnosis on the spectrum. Usually people are talking about autism here, even though like in the world of psychosis, we also talk about the spectrum of psychosis disorders as well. Special language, inclusive classrooms, PBIS, it's like positive behavioral intervention system or something like that, but that's mostly about like catching kids when they're good and being preventative. So that's a really cool program. 5150, like that's sort of like bringing people like into the hospital, hospitalizing people or detaining them for mental health concerns. That's probably not the right word, but ADHD, attention deficit hyperactivity disorder. Sometimes you hear like ADD in the schools, but I mean, they probably mean the same thing, but this is the formal word. All right, this is great. City boys, I don't know what that is. And this is why like having conversations like this will be good. I think Jen and Sam are creating and going to be sharing like resources that can like open us up to some of these things. I'm seeing more answers come in. Free appropriate public education, zones of regulation. Interesting. I wonder. I'm curious about that. So some parents will tolerate drug-induced psychosis instead of first break mental health symptoms. In terms of like the stigma, it's like more palatable. To have that label. All right, excellent. So lots here, lots of jargon, lots of things. Some things I get, some things I might get, but it means something different from me to them. So communication is key, and I see that I'm not alone. I think in struggling with some of the jargon. All right, so let's go back to the slides. Some of the jargon maybe we'll try to clear up, but others we'll still struggle with, but now we know that we're not alone. All right, so some like resources that hopefully Jen and Sam can share also. These are a couple of documents that we put out a few years back with the support of NASHBID and SAMHSA that were intended to help schools and school employees that had a student with psychosis. And then there was another like compendium, and that's the wrong word, like companion, that's the right word, companion document that we created for families to help them work with schools if they had a loved one with psychosis. And they're like pretty user friendly. These are the covers to them. And I think there's some good information in there. So I think this is one resource that I wanted to share. And in those docs, we define some jargon, including individualized education programs or IEPs, as well as 504 plans. And these are two options that many kids at risk for or with early psychosis are eligible for in terms of services. So what are these things? This individual education program and 504 plans. Well, they both can help. And I would say like in general, like IEPs are more stringent. There's like more layers to them. And they can be sort of like more comprehensive. They both offer accommodations, but 504s they're sort of more known for accommodations as opposed to revamping plans. So individualized education and 504 plans, they're designed to support especially initially students with disabilities. So an IEP plan specifically for students with disabilities who require special education services. It's developed by team professionals, including the students themselves, if they want to. They're not a required member, but the students' parents are, teachers, and other relevant professionals. The IEP, it outlines student-specific educational needs, as well as goals and objectives, and then the services, as well as like the accommodations that are necessary to meet. Now, the 504 plan, on the other hand, is a plan that provides accommodations and modifications to students with disabilities, but it doesn't include like specialized instruction. which is like sort of like a separate thing. It's designed really to ensure that students with disabilities or psychosis, in our case, in this conversation, have access to the same educational opportunities as their quote unquote non-disabled or more typically functioning peers. The plan, it's developed by a team of professionals also, and usually includes parents and teachers. It's a little less formal. All right, so eligibility, first, the eligibility criteria, they're a little different. To qualify for an IEP, a student has to have a disability that's recognized under the Individuals with Disabilities Education Act, or IDEA, which most folks have heard of that. And it requires specialized instruction. All right, so in contrast, to qualify for a 504, the student has to have a disability that substantially limits a major life activity, such as learning. All right, it's worth mentioning you can have both. They're not mutually exclusive. And this comes up when a student needs a plan for parts of their education, but can still learn with their peers in others. And that's a tenet of 504s. Learning with one's peers is a prioritization there. Let's see what else we have. What it does. All right, the services provided under each plan they're different. An IEP provides specialized instruction and related services, such as speech therapy or occupational therapy, whereas a 504 provides accommodations and modifications, and that helps the student access the general education curriculum. So like extended time for tests or preferential seating in the classroom, common 504 accommodations. The process for developing and implementing each plan is somewhat different. Let's see. An IEP, more formal, more comprehensive, requires a full evaluation of the student's needs, annual reviews and reevaluations every 3 years. Those are sort of like the rules of the IEPs. 504, less formal, may require full evaluation, but oftentimes doesn't. There should be like regular check-ins on 504s as well, and there's guidelines for that. All right, applicable laws. So the associated laws, the law with the IEPs are special education laws, again, IDEA. And then the 504s is more of a civil rights law, Rehabilitation of Act of 1793 or 1973, if you are curious about that. And let's see what else we have. Evaluation stipulations. So this is interesting, I think, that families can ask for independent evaluations in IEPs, but there's not the same stipulation for 504s. I think you can have an independent evaluation, but the school isn't, I don't believe, required to provide that for 504s. And then team composition, like who's involved. Well, for IEPs, it's pretty strict. The child's parent or caregiver, at least one of the child's teachers, a special education teacher, psychologist, or other specialists who can interpret sort of mental health or psychoeducational evaluations, and then a district representative. For the 504, it's a little looser. It could include the parent or the caregiver. I mean, it should include them. And then variety of different teachers, as well as potentially the school principal or representative thereof. All right, what's in it? Well, one note, generally speaking, an IEP, I should mention, it's like it takes longer to develop than a 504 plan because it's more comprehensive, there's more stuff in it, requires more extensive evaluation, and involves more formal procedures, including meeting with multiple professionals and developing like a specific set of goals and objectives. Now, in contrast, 504 plan, it could be quicker. I'm not saying it's going to be fast, but it could be quicker and tends to involve less evaluation. Focuses primarily on accommodations and potentially modifications that can be implemented and like relatively easy in a general education setting. Like I was saying, like, okay, 504 plans in place. Now the student can sit in the front of the classroom to avoid distractions, for instance. All right, the plans take different times, of course, and the length in which it takes to implement them can vary. I think it's important, this is just sort of anecdotal, but to make sure that to the extent possible that the parents feel empowered to advocate for themselves if they feel like it's taking too long or they want updates. Getting updates periodically is a good way to keep a process moving, and they shouldn't feel bad about asking about that. And I mentioned that these plans are not mutually exclusive. Okay, so I think one of the things that can be really like helpful, and I wanted to spend some time thinking about together and talking about, where this idea of accommodations. Now, the idea, like, accommodations can be really helpful. The universe of accommodations, it isn't completely limitless. There's like a set of accommodations that seem to be like agreed upon, that seem to be effective for most kids, irrespective of their mental health status, that need accommodations in an academic setting. So you see things here like therapy. I think that's good. Med support, like having a school nurse or someone at the school help with administering meds. Looking for symptom triggers. Alternative environments, or like, quiet space, or alternative assignments, like not having to speak, like give a speech in class, but instead like writing something or doing some sort of other test. Preferential seating, extra time. All of these things, actually, all these things would help pretty much any child, and any child with mental health concerns that are impacting their educational opportunities, and people with psychosis, where their psychosis might be impacting their educational opportunities. I think where it becomes more interesting is like tailoring these to make sure that they're implemented right, and that they fit the exact unique needs of the student with whom you're working. So it's the individualization where I think the creativity and the art comes in. Let me just open up for another Menti, since we did pretty well on that last one. Accommodations that might help a student with psychosis. So same QR code, but I think I have to open up the question. Give me 1 second while I figure out how I want to do that. And come on, don't let Demeter. There you go. Let's go to question number 2. And okay, accommodations that might help a student with psychosis. Presenting that, 1 moment. All right, now, okay, I'm seeing some answers come in, and I'm going to share them with you momentarily. Okay, accommodations, quiet spaces, good. That is really important, especially for kids that are experiencing hallucinations, or just or can't filter out extraneous noises. This list, as I'm seeing it go here, is something that we are going to save and share and be like I don't know, like a memorial of our time together, because I think that maybe that's the wrong word, but like a list of things that I'm going to actually use as to help inform my work, and think more creatively about different accommodations that might help a student with psychosis. Extra time on assignments. Earbuds. Yeah, earbuds are oftentimes reported as like limiting or minimizing the impact of voices, drowning them out. Preferential seating. Access to breaks or a quiet space. Yeah, and without like the teachers like giving them a hard time about it, just like, okay, it's cool. And that's sort of like I was talking about, like the individualization. I had a student where most of his teachers got it, but like one just like made him like come up to the class and like get the whatever, the stupid card, like the bathroom card or whatever. Like the kid just needed a break, and so I had to work with that teacher. I mean, the teacher was, they were acting from their own principles, which weren't bad, but some flexibility would help them. Distraction-free testing sites, hybrid scheduling, yes. Accommodating to the need of the student in that way, I think is really good. And also something that's better now because of all of our, our reliance on Zoom. Earbuds, adjusted deadlines, headphones. How about this one? I see a lot of inconsistencies with schools offering therapy check-ins during school hours due to space and liability issues. Usually they're contracted with an outside provider. Yeah, like how can schools be supportive of therapy? Just like we were talking about in the beginning. Like if you start therapy in schools, like it tends to like connect or catch. So schools are a good place for that. Breaks, adjusted deadlines. I love this. Excused absences, yes, especially for mental health appointments, without like having to stigmatize that or put it on the bulletin board. Reliable support person on site. I love that. Someone they can turn to. That actually can make all the difference for a person with psychosis or any student, really. Access to gen ed room through video technology, yes. Quiet room, remote working, quiet space for testing, extra time on test, breaks between classes, more headphones, places to pace. Reduce course loads, yes. Dimmer lighting, nice. And this is one where you wouldn't necessarily think this for everyone, but if you're working with a client and they like, like try it out, like say, okay, well, do you concentrate better here? Or, is the lighter better? Just natural light better, whatever. See what works for them. And that's, that's sort of the epitome of a person-centered approach to this. Reading tests aloud to students, that's good. And technology can help with that too. Wait time when asked a question. Yeah, that's good, because sometimes, especially people on some medications or who have negative symptoms of psychosis, there could be a delay or a pause between their like how long it takes them to process or to respond, and not assuming it's going to be immediate. Yeah, okay, awesome. Okay, these are really fantastic. Thank you all. We are going to keep these, and even more naps. Love it. Because of med side effects, at least even just like I want to go a little more because I love what you're sharing here. Even if it's not med side effects, but just fatigue from the symptoms or whatever, that's good. Naps. 2 people wrote that. Crisis plan. Okay, crisis plan, really important. I'm glad you wrote this. Where does the student go? Is there a quiet room? Is there a person that's like that helps them settle down? I've had a lot of success with crisis plans, and they really have to be tailored and individualized. Hobbies, good. Informing teachers, yes. Sometimes, like in these meetings, depending on what your role is, it could be your job to support teachers understanding what's going on here. Whether you're a mental health professional who's a psychologist or a social worker, or your mental health professional who's peer support and leader within your community, then and you're in that room teaching teachers about what this client might be experiencing. Really important. Okay. All right. Awesome. Thank you all for that. We are going to save these and continue to learn from them. Let's go here. Okay. On the topic of accommodations, there's a few resources I wanted to share. This is another screenshot from the SAMHSA toolkit that I shared earlier, but you see things like easily distracted. So maybe tape record class, books on tape. You have like a problem here, and then like accommodation that could reach it, like short attention span, book on tape, maybe extremely restless, leaving class for breaks. Okay, you don't always have to have the problem to the accommodation, but like understanding the problem can help tailor the accommodation. But more resources for accommodations. This is a resource that I think Jen and Sam shared with me from the Job Accommodation Network. And you can type in schizophrenia, and I mean, this is for jobs, but like it like generates a bunch of other ideas that might be applicable to the educational setting. And it's worth poking around in if you're interested. Similarly, Accommodation Central, another resource Jen and Sam shared with me. You put in some parameters and you see what it spits out. One of the things that I think is useful about both of these, actually, but this one in particular, is like it's not like disorder specific, but rather it's sort of like symptom or challenge specific. So you see here, it's like it says focus here. So maybe focus is the problem that they're struggling with, and maybe peer tutoring could be part of the accommodation or the solution. You've emphasized this throughout, but like this idea of like being creative is really, I think, where the action's at. Individualize things. And I really can't overemphasize that enough. I don't know that there's like, I don't exactly know what that, like how to operationalize that completely, other than to make sure that you listen to your client and their experiences, have some structured questions, and then understand the context in which they live so that you can have a sense as to what's possible and what's not. And in order, like in your listening and learning, that listening and learning can be from hearing things not just from the client or their family members, but folks on the in the schools, like teachers or nurses, counselors, administrators, even coaches, whoever interacts with the kids, they really know the kids really well. Stigma, I've alluded to stigma a bit, but stigma is so detrimental because it prevents people from accessing the help and care that they need, because they've internalized some of these negative things and they're afraid of what will happen if they share some of these things with them. Among many other reasons, stigma is bad. So mindful stigma, whatever your role is, maybe you can play a part in breaking down stigma. I know many folks are passionate about this, so be a champion. Be proactive with schools so that we're working more early than reactively, preventing crises before they occur. And this is sort of what we were able to do with Jane. And I'm going to circle back with Jane, that vignette that the family that I shared at the very beginning. I want to talk some more about our experiences working with Jane. Always follow the lead of your client and family. Priorities and prioritization should be driven by what they want. And that's true for so many different reasons. One of many would be the motivation that you'll gain from honoring the direction that they want to travel in. Of course, it should be a partnership, but being person client centered and empowering them to make decisions that are impactful for them, it's the way to go. And is another thing that I think that Jen and Sam are champions of, is this idea that recovery should be thought of as the expectation and not the exception, irrespective of where a person's is in terms of their mental health journey and their trajectory with psychosis. There's always hope, and our expression of that hope, regardless of what role you play, is potentially, arguably, one of the biggest tools that you have to increase positivity and to get to the positive outcomes that the client is wanting to pursue. Okay, so schools, obviously this kind of goes without saying, but schools are good, presumably most of them, some problems notwithstanding. But they provide people with work skills, peer skills, independence, support a well lifestyle, whatever, however you define well. I think about things like the importance of sleep, activity, food, a predictable, presumably in most cases, hopefully a stable environment, and hopefully, and to the extent that we can help, respect cultural differences and help people feel like they have a place that they belong. And so that's sort of the motivation of why we are having these conversations and why it's so important to work with schools and working with teachers in particular, which is that slide was sort of a segue to this. There have been many times when I've had to provide detailed psychoeducation to teachers about the particular needs of their student, and also the needs of students with psychosis in general. Because I mean, most teachers share the misconceptions that many people in the general society share about mental health concerns related to psychosis. Like, for instance, they're afraid that the person with psychosis is going to be violent, and that's generally not usually the case. So teaching them about symptoms and how to manage them, and also how these symptoms manifest themselves for their particular student and how they can best support the student, it can go a long way. I think one of the most important things is to help teachers see that it's not like the attribution. So it's not like their student is like trying to be bad, like to get under their skin, or doesn't like them or whatever. It's like they are grappling with some internal stuff that is well beyond the control in large part of the teacher, but that could be supported by the teacher. And so when the teacher understands that it's not like they're not trying, or that they don't care, or that they're bad, then teachers can become really great advocates and support systems, the best in some cases for students in schools. I would be remiss if I didn't just at least briefly mention that people with psychosis are far more likely to be victimized than they are perpetrators of violence, and bullying is a big consideration here. In schools, bullying shouldn't be tolerated. I know that's sort of like a belief or value that I have, but increased adult supervision in the case of bullying is important, and just being sensitive to the possibility of bullying for your client or the person you're working with or partnering with could be really important. Also, especially in the early phases of psychosis, suicidality becomes a really prominent consideration. 2 in every 3 people that's identified as at risk for psychosis report suicidality, active current thoughts about suicide. And then 1 in every 5 have reported a lifetime attempt of suicide. These statistics are strikingly high, and one of the main reasons is in the early phases of illness, people are grappling with insight, and they understand that something's different or wrong or not or atypical in how they're and changing in their experiences, and they see their mental health as sort of unraveling at times. Like Jane said, she felt like she was going crazy, and in those cases, people become more hopeless, and it puts them at more risk for death by suicide. Now, we have a suicide reduction program that's based in the model by one of our colleagues in Michigan. It's called Youth Nominated Support Teams, and it expands the number of folks that could be part of the treatment team to help reduce suicidality and help the client stay engaged in treatment specific for folks at risk for psychosis. So I think wrapping people with support, warmth, compassion, friendship can help reduce this. And I mentioned stigma. I won't go into that anymore, but I will say that all folks, irrespective of their mental health concerns, irrespective of their status with respect to psychosis, are far more similar than they are different. So the things that people with psychosis like and respond to and would be effective with are in many cases the same things that anyone, irrespective of their mental health status, would like and respond to and would want. So as we're heading towards the last 20 minutes or so of our time together, I wanted to circle back to a conversation about Jane. So Jane, as I mentioned at the very beginning of our time together, 17-year-old, she was a junior in high school when her mom called. And her mom was interested in preventing a negative trajectory that she had seen in Jane's older brother, Thomas, who developed schizophrenia in his early 20s and now was pretty pronounced in terms of his symptoms and was sort of separated from the family. Jane, on the other hand, was much earlier in the course of concerns with respect to mental health. Prior to her junior year, she was functioning fairly typically, actually quite adaptively, but she had some mental health stumbles her junior year, and her mom reached out to me. So I'll read this vignette, and then I have like some questions, and then Sam and Jen, I don't know if there's ways we can interact with this, but if folks are willing to type in somewhere that you all can read it, you all can kind of free flow with this. Sometimes I refer to this as like water flowing. So I'll ask an open-ended question, and then y'all just like put it in the chat or wherever, and then Jen and Sam, it'll be nice to hear another voice at least. So okay, so Jane, she has recently started experiencing early signs of psychosis, such as hearing mumbled conversations when no one was around, and having beliefs that she could predict the future. She began acting in accordance with her predictions and was becoming preoccupied with them at the expense of her social relationships. Seeing groups of other kids triggered her to hear the mumbled conversations, which she tended to interpret as the other students perhaps plotting against her. Ms. Smith called my team for an evaluation. After a thorough diagnostic interview, we determined that Jane was at risk for psychosis based on attenuated symptoms, so lesser subthreshold symptoms of psychosis, along with a family history and functional decline. We also learned about many of Jane's strengths, including a strong group of friends that were sticking by her despite her recent challenges, solid pre-symptom functioning, a mom who would do anything for her, and an engaged school with teachers, counselors, and administrators who cared. Jane was struggling academically, but wasn't failing, and teachers and Miss Smith wanted her to remain in her current classes. All right, so I think I have okay, question one. This is sort of like an easy one to get your fingers warmed up. Given the last statement that she wasn't failing, but her folks wanted her to stay in her current classes, do you think an IEP or 504 would be better? Now, let me just say that I think the next questions are going to be a little bit more open-ended, but this one, true or false, yes or no, IEP, 504.
Jason, we've got a lot of responses coming in, which is exciting. I'm seeing kind of half and half here. Sam, what do you think? I'm scrolling as we're looking here.
I know I'm seeing about half and half as well, actually.
Nice.
Yeah.
Okay, yeah. So you could make a case for an IEP based on growing symptoms of psychosis. And if we learned more, and this is the downside of like vignettes. But if we learned more that her symptoms related to psychosis were impairing and needed an entire revamp of her educational experience, whereby she was sort of taken out of her typical classes and no longer working with or learning with her peers in the typical classes, then IEP would be, if we learn that stuff, then IEP would be a good route. If she wasn't failing, but maybe falling behind a little bit, and there seemed to be an impetus for teachers and her mom to keep her in the class, an argument could be made for a 504 as well. And I think that, so there's no wrong answer really to this one. It really depends on more context and what more information we would have. So either one would work. In real life, in Jane's case, 504 was the avenue because, excuse me, the nature of her symptoms were attenuated to the point where she was still able to remain somewhat focused with accommodations. Okay, good. All right, thank you for that. All right, let's read on. So I have the first part of the vignette up in smaller font, so in case you want to refer back to that. But I'm just going to read the second part here. The team agreed that a 504 would be better for Jane. It's like a choose your own adventure, I guess. With respect to Jane, how Jane was doing in class, her teachers described her as anxious, and Jane said it was difficult for her to concentrate in class. She was turning in work late and not finishing assignments in class. Academically, many of the accommodations that seemed best for Jane seemed good for any student, regardless of diagnosis, who had similar problems. Okay, so that's a theme that we've been touching on, which is like, the universe of accommodations isn't, limitless. And accommodations that seem to work for kids with psychosis seem to work for kids without psychosis and vice versa. So next question I have, what accommodations might you recommend in this situation for Jane? Pop them in those chats, and Jen and Sam are gonna read the waterfall.
All right, so we have lots of answers already coming in. We have
Nice.
peer tutoring, using headphones,
Mhm.
extra time for completing assignments. A couple of people saying extra time for assignments. A couple of people saying quiet places to work on assignments, allowing to turn in work late, peers, working with peers. Ability to leave the classroom when there is increased anxiety or having some kind of a de-escalation space. Oh, I love this comment. Ask Jane. She knows herself the best. From James. So that's really nice, James, to say, this all should be done. Of course, we're doing this kind of abstractly as a case example, but of course, in real life, you would want to ask Jane. So that's absolutely great reminder. Extra time for assignments, smaller assignments, nonverbal tool. One-to-one coaching, adjusted deadline, quiet space. Awesome.
I wish I could have had all 500 of you at that meeting, 246 at that meeting, because there were some themes that you hit on, which actually the most important one was like, what does Jane want? And that's where we started. So I love that. But extended time on exams, and we have to come up with like a reason for it and like why it might work, and that's sort of the individualization of it. But alleviate the stress and anxiety that comes with time constraints. Preferential seating, that helped her focus a little bit. Note-taking assistance, so she was allowed to like record without like any fuss about that. Flexibility in attendance and assignments, and that accommodation about absences and extended deadlines, those were really useful for her. She kind of got back on her feet. Mental health services was a big part of it, and the school supported that, which was good. I mean, and actually it was sort of like, I was able to, our team was able to provide services, and then there was like another mental health team, and we were able to collaborate pretty well. That was like from the school. Alternate exam formats. This was something actually that we got specifically from Jane. I mean, this is something you could ask anyone, but like Jane, but it could be opposite for somebody else. Like Jane did better with multiple choice questions than traditional essay style exams. So the teachers were pretty okay with that. And they went out of their way to actually help her to create different testing formats, which as a professor myself, that was really appreciated, because that's really extra for them, just for her. All right, excellent. Okay. All right, so she was worried. Okay. Oh yeah. Okay, so this is good, because there was some strategies that you mentioned, that Sam, that you read, that people contributed, that we integrated later on in a different format than the accommodation. So Jane was worried that her classmates were possibly plotting against her, making group projects particularly challenging. She also began spending more and more time thinking about her ability to predict the future. Question here: what strategies might be worth considering to target these concerns? What therapy strategies or academic strategies, or whatever your role is, what could you contribute, or what does your discipline or perspective, what could it add to strategies that might be worth considering?
All right, Jason, I'm seeing some suggestions come in, and know we have folks across all roles. So I'm seeing peer support, and Aisha, I hope I'm reflecting that correctly, because Aisha did write it as peer, all capitals, PEER. And so I don't know if there's a particular modality I'm not familiar with, but peer support or peer CBTP, helping her put into context the thoughts of her peers plotting against her from CBT. So like having a strong conceptualization of that. Jane being able to work with her own partners, to choose her own partners academically in school, modifying the assignments to do solo instead of a group, supported employment and education, coping skills and mindfulness, asking questions about her concerns, seeing some DBT skills, and focusing on her feelings. So this is a very interesting question from Andrew. What does she gain by having these thoughts, right? So kind of this idea of like, do these thoughts serve a function? And is there any way to address that function differently? Oh, interesting. Ask teacher if it's possible to toss the ball with the team. It puts people in sync and shows her trust is possible. So doing something kind of physical. And we did also get some comments about like somatic therapy. So that's kind of an interesting theme emerging, providing some psychoeducation. Yeah, I think those are the main themes there.
Awesome. Yeah, and so this is the one where I was eager to get to this slide, because for Jane, peer-to-peer mentorship was really important. Like, she had a built-in group of friends already who continued to support her, and she could benefit from sort of professional peer mentorship, if that's not the right word, but like peer support was really important for her. We had to work a little on social skills and kind of break down some of the challenges she was having in terms of like her growing suspiciousness, like the Socratic conversations about her friends. That's CBT approach to helping her understand like her reactions to her friends kind of being out to get her, having alternative explanations. That was part of the CBT. And experimental hypotheses for future testing, another CBT skill. But peer-to-peer and then stigma reduction for the school, actually. So it wasn't just, it was like some of her classes, the teachers like were better, actually pretty good about like integrating mental health into their curriculum a little bit without being like too like overt about it being for Jane, and just normalizing some things that can be helpful. I didn't do this in Jane's situation, but I've gone to like schools and like done like assemblies where I like talk about mental health and symptoms related to psychosis specifically, in ways that I think normalize it and reduce some of the fear, and highlight this notion that I've repeated a couple of times now, that people with psychosis are far more similar than they are different. All right, cool. So professionals. So this is question number 4. Some of the professionals, as we're writing down here, some of the professionals on the team didn't subscribe to our clinical formulation. One mental health professional contended that the problem was autism. One teacher was afraid that her unusual behavior, she sometimes would spontaneously grimace, portended violence. Another teacher said she needed to suck it up. Not a lot of empathy from that one. Her coach was confused, and her nurse was demanding pharmacological care. In the interest of time, I'm just going to go ahead and drop some. Sam, give me, so type some stuff in, and Sam, give me the first few, and then I just want to make sure I'm respectful of everyone's time.
Absolutely. So the question is, how would you work with these unrelated differences of opinions? So we're getting educate all parties, do something to get everybody working together. I'll take one more. Oh, nice. Validating concerns of each party.
Mhm.
Psychoeducation.
Yes. Psychoeducation, validating. I love it. And it's just sort of like taking the time, like it just is really important. So more similar than different, psychoeducation for violence, medication consultation, other things. Let me just wind down here a little bit. I just want to emphasize one last point and then open up for a few minutes of questions. But mom was extremely worried. So what ways could we best support Miss Smith? And I'll give you what we did here. And I humbly submit that there could have been more, and that I know now that you all would have ideas that would further this. But respite care, support group, that from NAMI, in that case, the therapies, psychoeducation. There was some practical assistance that she needed, advocacy, and then like really encouraging communication across. So that was what we sort of thought about. And all of this, as I'm winding down here, is like, in large part catching Jane here, working with the schools, and sort of altering her trajectory in a way that didn't line up with her older brothers. And then the last thing that I thought I would end with is, as opposed to like sort of a summary of everything, is just like these principles and those pictures, I think is pretty good. These are some supportive principles that I think should stick with us when, even if we're not like formally working in a supported education space, but like supporting a kid in schools. These are good principles, that everyone should be moving forward and learning. Folks should be able to go to school. Earlier is better. Mental health care should be integrated, not time limited, driven by the client, and strengths based, with the notion that a student and their role is meaningful and important. And I have some references at the end, and we have like 4 minutes for anything else that we want to talk about. So thank you for sticking with me.
Jason, that was amazing. And thank you so much. We have a number of questions. Sam, I'm going to go ahead and pass the baton to you for those.
Thank you so much. And I do want to say we got a ton of questions, Jason, as you were talking, so we will not be able to answer all of them, unfortunately. But let's go ahead and jump into what we can, and then we'll try to answer what we can post this webinar as well. So one of our very first questions was about how you can work with a teacher who doesn't understand maybe psychosis and is worried about altering the workload or reducing a workload because it sets kind of an unfair, in their mind, sets an unfair expectation for other students.
Yeah, I mean, let me empathize. Like, I want to give, like, yeah, I mean, like, literally, I was dealing with this yesterday, where the teacher had values that I think were consistent with my own, and I think what were in the best interest of the student, but they just expressed it in a really different way that was not really supportive of the student, but was a value that was like about education and fairness and learning and stuff like that. And so I think, I don't know, I mean, like, eventually there's sort of like a compromise, but like really like listening. And the thing that I was finding myself, like encourage, like my little inner angel was like on my shoulder saying, just keep listening, don't attack, don't like say, oh yeah, but it was just like really trying to understand where they're coming from and honoring that, and then helping them see some of the gray, and also like some of the value in being flexible, because if there's challenges that are emerging from one student, if the teacher is able to help that student, then like it serves the whole good of the class. So like there is value in and sharing gray with people, and it's not always black and white, and that the rules are created for most people, but like they have to be tweaked for people that have unique circumstances. So I mean, long story short, understand their values and listen. Really take the time. Like, don't go in there thinking like, I'm gonna just tell them what's right. Yeah, but not an easy.
Yeah.
There's no easy answer.
Fantastic. I really appreciate that, Jason. Let's see if we can squeeze in one more. I think this is a really interesting one. If a student is concerned about privacy but wants accommodations, how can you ensure that you're implementing accommodations while still protecting a student's privacy, especially around their diagnosis, if they don't want that to be known?
Yeah, that's a tough one too, because I mean, I think working with the school counselor is probably the first approach there, and finding out what the rules are and how they tend to approach this with respect to, you know, what's like the least amount required, and who needs to know, and what they need to know, and if an advocate is available, like that works outside of the school to help them navigate that, you know, like the least, what there's some, you know, the least amount of now information that's required is perfectly fine. So, you know, I think that that's a great concern, and like doing your best to assure the student the privacy that they want, and also getting the accommodations that they deserve. You know, that should be a goal. Excellent consideration. Yeah. So I know it's time to go, but thank you all so much. It's been a real pleasure. I love it. Thank you.
Thank you,
Thank you,
Jason.
Dan. Thanks, Sam.
You are so welcome. We appreciate your time. We honor everyone's time here now. Thank you. We will get everyone the recordings, CEUs, and copies of these resources. So anticipate that being emailed to you all. Thank you again, Jason. You're top notch. Okay, we'll go ahead and end the webinar for today. All be well.
Everyone.
Bye-bye.